Today we will discuss a subject which I think is important for most of us who are treating diabetic patients during Ramadan, which is the sulfonylurea safety in Ramadan. When I think about this question, I found myself I have to answer some questions. Number one, should we worry about sulfonylurea in Ramadan? And to answer this question, I found myself asking myself more questions. What do we know about sulfonylureas? All of us are writing sulfonylureas, but what do we know? Is our knowledge enough to judge if sulfonylurea is safe or no? And then can we put all sulfonylureas in one basket? And on the other hand, what are the main risks of fasting, and what are the recent studies and guidelines to give some answer about these questions? And at the end, of course, our target is how can our patients fast Ramadan safely? Sulfonylurea and their use in clinical practice. It was stated that sulfonylureas were discovered very long time ago, in 1942. By chance, when it was found that some sulfonamides generated hypoglycemia in experimental animals. And from this time, the first sulfonylurea was carbutamide, which was the first sulfonylurea used to treat diabetes, but it was withdrawn rapidly because of side effects. But again, because this group is very effective, by 1960s, we have a lot of sulfonylureas, and we are now using some of them, which are the second generation, gliclazide, glipizide, glibenclamide, and glimepiride. And the first generation, tolbutamide and chlorpromide, are no longer used. This is the mechanism of action of sulfonylurea. If sulfonylurea will bind to the receptor here, this sulfonylurea will bind to the receptor. This receptor is ATP-dependent potassium channel. This will block the inside going of potassium, and this will cause depolarization of the membrane. This depolarization of the membrane will open the calcium channel. Calcium will go inside the beta cells of the pancreas and stimulate the actomyosin filaments and result in exocytosis of insulin. What's important here is sulfonylurea is working in glucose independent manner. It means that sulfonylurea will work whether blood glucose is high or low. So the main side effect of sulfonylurea is hypoglycemia. But again, let us see in more details this mechanism of action. This ATP-dependent potassium channel is a heterooctameric complex of two different types of protein. What's called inwarding rectifying potassium channel, which will take potassium inside the cell, and a sulfonylurea receptor. And more than one isoform exists for both these KER6 and sulfonylurea. These receptors, the ATP-dependent potassium channels, are also found not only in beta cells of the pancreas, but they're also found in other types, including cardiac, smooth, and skeletal muscles, and some brain neurons. And it was found that they are involved in the response to both cardiac and cerebral ischemia. They are important in neuronal regulation of glucose homeostasis, seizure protection, and the control of vascular smooth muscle tone. What's more interesting is that it's well established that the sulfonylurea receptor can modulate the activity of KER6.2, and also the KER6.2 can affect the properties of sulfonylurea. It's not a simple attachment and action. There is interaction between different parts of the receptor. And co-expression of KER6.1 with sulfonylurea 2A or the mutant sulfonylurea 2B has been shown to increase the affinity of glibenclamide by 5-fold. It means that different people with different genetic architecture can have different response to sulfonylureas. And from here, I will end my lecture about the future using of genetic studying to choose the proper dose of the proper drug for a proper patient, which we call it precision diabetes medicine. Moreover, sulfonylureas and glanides can be divided into three groups. The first include natriglanides, tolbutamide, and gliclazide, which are molecules bind specifically the A site of sulfonylurea A. It means that not all the drugs combine the same receptors in the same affinity. Different sulfonylureas have different affinities to different types of sulfonylureas. Besides possible alterations of absorption and metabolism, genetic differences can also change the response to sulfonylureas. And in recent years, genetic failure to beta cells has been demonstrated. So this is the basis of using the precision medicine and choosing the proper sulfonylureas. And in the end, they stated that sulfonylureas are not all alike. They differ in their dosage, rate of absorption, duration of action, route of elimination, and binding site on their target pancreatic beta cells. So the first part of my question is, are all sulfonylurea are the same? The answer is no, of course. Not all sulfonylurea are the same. And these are the group of sulfonylurea: tolbutamide, glibenclamide, glimepiride, glipizide, gliclazide. They have differences in the dose and duration of action, activity, elimination, and structure, affinity to the receptors. And the conclusion of that paper was that despite the great number of antidiabetic agents currently available in clinical practice, sulfonylurea are still frequently used. This is what we are using in our clinic. We are still using sulfonylureas. Maybe this is due to their lower cost, maybe long experience of patients and physicians also, possibility of monodosing and the presence of an association with metformin in the same tablet. Considering adverse events, we have to appreciate the sulfonylurea, especially the older one, are linked to greater prevalence of hypoglycemia and cardiovascular risk maybe. But now we know that sulfonylureas are a heterogeneous group of drugs, and the effects of a single drug are drug specific and not a class specific. In Ramadan, of course, it's important that as my all colleagues are trying to address the problem of fasting, because we are in an area where Muslims are a big percentage. And as Dr. Shireen mentioned, that the main changes during Ramadan is the time of eating, there is prolonged fasting, and the disturbance in sleep. And there is a review in 2020 which said that because of the fasting, there is gradual shift in the proportion of fuel utilization from carbohydrates to fat as the fasting day progresses, and this predisposes patients to DKA. There are some hormonal changes, but what's important here is that there is change in the gut microbiota. And gut microbiota are recently linked with the inflammatory reaction in the body of patients with diabetes and atherogenesis, and it was found that recurrent circadian fasting improves blood pressure and biomarkers of cardiometabolic risks. Maybe this is, the opposite of what we are trying sometimes to say, that fasting is put the patient in a dangerous situation, but actually there are some studies that actually fasting improving the inflammatory milieu of the patient. The main risks of fasting is hyperglycemia, hypoglycemia, diabetic ketoacidosis, and dehydration. The main challenges here, as we are all stressing, the eligibility of the patient to fast, managing the risk factors, adjusted diet, exercise, drugs, and the glucose monitoring. What I want to say here, that there is this study, READ study. It was studying, the aim of this study was to determine the impact of Ramadan-focused education on weight and hypoglycemic episodes during Ramadan, and it was found that those who doesn't have education have hypoglycemia 4 times than people having education. So this is number one. Before saying that sometimes fasting is dangerous or it has a deleterious effect, if we try to educate our patients how to fast safely, how they can check blood sugar frequently, they can fast safely most of the time. And these are the 7 times which the patient should have to check his blood sugar. This is what's called flash monitoring, glucose monitoring, which is now available in some countries, like in Saudi Arabia. This is the sensor is inside the skin, and the patient can just touch the glucometer on the skin. He can get the reading. موجود هنا. This will help the patients to get continuous, near continuous glucose monitoring in our days. Let us see the studies assessing the safety and efficacy of hypoglycemia. This was the first study, maybe one of the earliest study in 1993, and they concluded that glibenclamide is effective and safe for patients with non-insulin dependent diabetes who fast during Ramadan. This study was on Morocco on 500 patients. They took patients on glibenclamide. Some patients fast and the others didn't fast, and they found no great difference in hypoglycemia and safety. Also, glimepiride, they assessed the safety of glimepiride in another study, the GLERA study, which was in 6 countries. And even glimepiride with the insulin glargine, and they found that these patients can fast safely. Here, this is a nice study because they study the incidence of hypoglycemia in Muslim patients with type 2 diabetes treated with sitagliptin, a DPP-4 inhibitor, and sulfonylurea. And it's concluded that switching to a sitagliptin-based regimen decreased the risk of hypoglycemia, which is logic. If we are always switching our patients from sulfonylurea to sitagliptin, it reduced the risk of hypoglycemia compared to those remaining on sulfonylurea. But take care, they said the incidence of hypoglycemia was lower with gliclazide relative to other sulfonylurea and similar to that of sitagliptin. So the incidence of hypoglycemia with gliclazide, one of sulfonylurea, was similar to those with sitagliptin, which is DPP-4 inhibitor. So not all sulfonylurea. If we take sulfonylurea as a group, hypoglycemia is more than DPP-4 as a group. But if we take certain drugs, maybe they will have the same number of hypoglycemia. Another study, very nice study, because they studied frequent patient-physician contacts and Ramadan-focused advice assessing vildagliptin and gliclazide also. And again, they stated that vildagliptin was shown in this interventional study to be an effective, safe, and well-tolerated. It's okay. But they said, in contrast, gliclazide showed a lower incidence of hypoglycemia in the present interventional than in the previous observational studies because of the good contact between the physician and the patient. This meta-analysis, systematic review and meta-analysis, said that majority of patients with type 2 diabetes on sulfonylurea in clinical trials remain relatively free of severe hypoglycemia. Gliclazide was associated with the lowest risk of hypoglycemia. This narrative review was published in 2020, just a few months ago, and they said that use of glibenclamide has been shown to result in more hypoglycemic events when compared to glimepiride, gliclazide, or ribaglinide. The use of the older and longer acting agents should be avoided during Ramadan, and the patient switch to newer sulfonylurea or ribaglinide. And this study, which is a real-world study in patients with type 2 diabetes mellitus treated with gliclazide modified release, published also in 2020, and they concluded that patients with type 2 diabetes can safely fast during Ramadan. And because of this, in 2021, the DAR IDF guidelines say it's simple that if the patient on sulfonylurea once daily, he can take the sulfonylurea before iftar. If twice daily, he can take the morning dose before iftar and the evening dose before suhoor. And if the patient is taking glibenclamide, maybe we can switch to the newer one. And here just I will end by the precision medicine in diabetes. And we said that genetic testing can also help in expecting the pharmacokinetics and pharmacodynamics of some drugs, like what they said in 8% of the white population, they found more results with sulfonylurea. And by this way, we can refine our use of drugs in certain patients. At the end, I want to say that there are proven metabolic benefits of Ramadan fasting in healthy as well as diabetic patients, but if they follow a good lifestyle. But we cannot deny that there is acute metabolic derangements and medicine-related side effects which we should address and manage. Pre-Ramadan assessment and education and the frequent self-monitoring during Ramadan is the cornerstone of safe fasting. The newer generation of sulfonylureas, glipizide, glimepiride, and gliclazide are associated with a lower risk of hypoglycemia and therefore safe to be taken during Ramadan. And thank you very much.